Good afternoon, everyone. Welcome to the Bolandic Building. Welcome to the Mental Health and Addiction Committee, and we have members of the Veterans Affairs Committee sitting in, listening in virtually. We're so excited to get going. We are ready to begin. So we're going to start, if LAS and the clerk are ready. Because the hour of 1 p.m. has come and gone, it's 1:06. We're going to officially call the House Mental Health and Addiction Committee to order. Okay. And clerk, please call the roll.
LaPointe.
Here.
West.
West is here.
Haas.
Here.
Cassidy.
Recording in progress.
Costa Howard. Davis.
I'm here.
Ford.
Here.
Gill.
Here.
Grant. Guerrero Cuellar. Kazardi.
Kazardi's here.
Hodder. Johnson.
Here.
Lilly. Myers Martin. Morgan. Morris.
Here.
Mussman.
Here.
Severin.
Here. Good afternoon.
Tipsword.
I'm here.
Weber.
Weber is here.
With that, Madam Chair, there are 13 members present.
Howder is here.
Make that 14, Madam Chair.
Excellent. And I just want to say thank you to Minority Spokesperson Representative Jackie Haas for being here in person. Really appreciate that. I know you don't live around the corner, so we appreciate that. And I want to send a special thank you to Representative Swanson, the chair of the Veterans Affairs Committee in the House. There's a lot of overlap here, and that's why we invited members of the House Veterans Affairs Committee, and we're lucky to have just a lot of crossover in membership of our regular mental health committee with the Veterans Affairs Committee. For those here in the audience, I want to point out that there is a physical copy of the agenda on the table near the door of this room, and you are welcome to come up and snap a photo of it if you want to follow along with our agenda. So we're here for a House subject matter hearing on psychedelics as behavioral health treatment, House Bill 1 and beyond. We do have a solid agenda it's filled with witnesses who are clinical behavioral health professionals, veterans, consumers, AKA patients of various psychedelic treatments for behavioral health. And of course, we have the lead sponsors of what in the House is known as House Bill 1, the CURE Act. Here, there's a different Senate numbering of the bill, of course, so we're going to hear from Senator Ventura and Representative Ford. I want to highlight that the witnesses that I mentioned are not fixed categories. We are all humans, we all have intersectional identities, and so we're going to hear from people who are all these things at once. We're going to hear from a handful of people who are not only licensed behavioral health professionals themselves, but they are also veterans, and they are also people who have struggled with PTSD, and they are also people who have utilized psychedelics to heal. Those witnesses hail from right here in Illinois and also from Colorado and Oregon, and those two states, Colorado and Oregon, are the two states that have moved forward to set up a legalization framework for psychedelics. In sum, we have a lot to learn. This hearing is just one touch point in all of that learning to explore what exactly is the potential of psychedelics for behavioral health treatment. Just want to quickly touch on behavioral health needs and treatment because that is core to this conversation. As I say at every hearing of this committee, we are in the midst of a behavioral health crisis in this country and in this state. And that includes mental health, it includes addiction, it includes an urgent need for trauma support. We're at a moment where behavioral health needs are higher than they've ever been. We all live this every day. on a positive note, we're at a moment where people's willingness to seek behavioral health treatment and support is higher than it's ever been, in large part because I would argue that stigma is lower than it's ever been, which is a tremendous thing. The workforce, however, as we all know in this committee, is more stretched than it ever has been. More than ever, people are reaching out for support and they just can't get it. Too many professionals have months-long wait lists, or they don't take insurance at all, or they don't take that kind of insurance, or they don't take Medicaid. This committee and the entire General Assembly is going to remain dogged on all of those issues that are about behavioral health access. But I feel really strongly that it's also our responsibility to think outside the box, to truly listen to people when they say that the is not working for them, and more importantly, when people are able to find approaches that are working for them, it is our responsibility as policymakers to take a really thoughtful look and listen to those voices. And really that's in large part what this hearing is about. And of course, we're going to go into depth into House Bill 1 and the CURE Act. So with all that in mind, we're going to move forward, and just for a little logistics, I love how everyone went up and took a photo of the agenda. We try to be as accessible and transparent as we can. We are going to have a first panel, which is more or less a clinical perspective, but we all have intersectional identities. And then we're going to do Q&A of that panel. Then we're going to have a panel on personal impact perspectives. We're going to do a little Q&A on that. And then we're going to hear directly from the Illinois Psychedelics Society and Senator Ventura and Rep. Ford on House Bill 1. The witnesses are both in person and hybrid. So for those who are here, I'm going to invite, or to be ready on the Zoom. Okay, so for those who are here in person, Dr. Nazeer, Jessica Punzo, Dr. Holden, MicKensy, Ellis-White to come up to the table so we can get going. And for those who don't know all the logistics, the witnesses are going to try to keep their testimony to under 5 minutes. So we're not here till deep into the night. And for the clerk, virtually we're going to add Representative Myers-Martin, and here in person we are so grateful to have Representative Tara Costa-Howard. Okay, and one more piece before I get going, because I use some erroneous language here. We know that the actual chair of the House Veterans Affairs Committee, Representative Lance Yednock, I believe, is listening in virtual, and Representative Swanson is the minority spokesperson. Everybody gets jumbled now and then, so I appreciate your grace with that. Okay. Do we have Dr., excuse me, we've got some titles here, LPC, Doctor. Do we have Richard Snyder over Zoom ready to testify?
Hello, yes, I'm here.
Excellent. We're going to try to pump up your volume a little bit. Can you slowly introduce yourself so we can test the volume, Drew? I'm Richard.
Yes, how is this? Is this a little better?
A little better. We're gonna try to pump it up a little more.
Check, 2, 3, 4. Can you hear me now? Let me know when you want me to get started.
That is good. We have pumped it up to a good level.
Okay.
Drew Snyder, take it away.
All right. Good morning, everyone. Thank you so much for having me. Good morning, representatives. Really appreciate the opportunity to speak to you. My name is Richard Drew Snyder. I go by Drew. I'm a licensed professional mental health counselor in private practice in Ashland, Oregon. I'm also a licensed psilocybin facilitator and work in Oregon's legal framework. And I want to give you an idea of what that looks like and a little bit of an idea of my story. I'm also a veteran, and I've benefited from this personally. And so all of these intersectionalities, I think for me, they do weave together, and so I'd like to tell you a little bit about that. And I also really want to urge your support for the regulated and legal use of psilocybin in these therapeutic settings. As a veteran and a mental health professional, I have seen the profound impact that this treatment can have on individuals who are suffering from PTSD, from depression, from anxiety. And I'm also the lead trainer for the Integrative Psychiatry Institute. And they have a year-long program for psychologists, psychiatrists, therapists to learn psychedelic-assisted therapy. And under that program, I've had over 700 people come through this program and do psilocybin in Oregon as a part of their training with me, and I've facilitated those journeys for these psychiatrists and psychiatric nurse practitioners, therapists, and all of the healing that I have seen from these hundreds of mental health professionals and the inspiring things that we've seen is so transformational. And so I want to tell you a little bit about that as well. First, I'm going to start with my own journey of recovery. In 2010, I enlisted in the Army, and I served honorably until my discharge in 2017. And during that time, I earned 5 Army Commendation Medals. I completed a combat tour in Afghanistan as a human intelligence collector. I was later attached to Special Forces in Africa, trying to combat terrorism from Northern Africa. And while those missions, I think, were essential, it was very difficult and complex issues, and they left me with a lot of existential wounds and moral injury. And that began to take a serious toll on my mental health. I began experiencing severe PTSD. I had so much anger and anxiety, memory issues, and it really strained the relationship with my family and my children. And I realized I needed to, pursue healing and so I got out of the Army. And with that diagnosis of PTSD, I was prescribed a grocery bag of medications. I was doing years of talk therapy, and those things were getting me functional, barely, but I was not healing those wounds that really were at the core of this and why I had that PTSD. In 2019, I heard about psilocybin mushrooms being a potential treatment for PTSD, and I started looking into it, looking at all the research, and I realized this was a last-ditch effort to help me to reclaim my mental health, to heal that moral injury. And I had a therapeutic journey that was profound, transformative. I was able to access and heal these deep wounds in my psyche. And it was just days after that, my wife, I remember standing in the kitchen, my wife was talking with me, and she said, I feel like I have my husband back, like the man that I originally married. And that, alone was worth, doing that. So having that experience, made me realize I wanted to help bring this to other veterans, other people who have experienced trauma, who have mental health issues. I became a mental health counselor, and then when Oregon passed their legal psilocybin program, I became a licensed facilitator under Oregon's program. I have witnessed countless stories of healing and transformation, and the vast majority of feedback that I've gotten in these hundreds of journeys, psilocybin therapeutic experiences that I've personally seen, has been phenomenal and so exciting. The implications for the mental health crisis that we are experiencing, I think there's nothing else that compares to what is possible if we do this in a safe, regulated, and therapeutic way. There's so much peer-reviewed research that is out there, which demonstrates the potential of psilocybin-assisted therapy to address these public health challenges. There's a study that was in the JAMA Psychiatry journal, and it found that psilocybin-assisted therapy was 4 times more effective than traditional antidepressants in reducing depressive symptoms. Another study that I'm aware of found that 60% of participants with depression showed a decrease in symptoms, and 53 had complete remission at 3 weeks after just one psilocybin journey. I urge you to look at the programs that Oregon has in place and Colorado is putting into place right now. And those models, they include strict licensing requirements for the facilitators. There's standardized training protocols and safeguards for the clients. All these things to help regulate the space so that the treatments remain really effective for people, and because this is a very powerful medicine. But in these programs, I think they've been very successful. There have been, in May, Oregon hit 3,500 clients that were treated, and with very, very few issues with that. So I really think that the benefits of this are going to be improved mental health for the state of Oregon, for all these people that are coming and trying to heal these deep-rooted mental health issues that they're struggling with. And I think it's cost-effective. It's years of therapy in one journey often. And I really think it's going to help address the mental health crisis. So I really encourage you to champion this legislation and play this pivotal role in transforming mental health care. So thank you for allowing me the opportunity to speak. I'd love to answer any questions you might have.
Thank you so much, Richard. Your perspective from halfway across the country is very important. It's very valued. If you can stick around to the Q&A portion, we would love to have you.
Thank you.
Next, we are going to turn it over to Dr. Nazeer. Just press the button on your little machine.
Thank you for the opportunity to speak today in support of HB1, the Cures Act, and really advocate for psychedelic medications in an integrated medical model of care, and bringing this treatment to many in need. I'm a board-certified psychiatrist. I also have a board certification in addiction medicine. I'm the founder and chief medical officer for Hope Mark Health, where we focus on treating individuals that have mental health conditions that are not responding to traditional approaches. So we utilize IV ketamine, ketamine-assisted psychotherapy, Spravato, TMS, as well as all the general options that are already available today for us. It is really, I've seen firsthand as a clinician with direct experience, so many lives saved in my practice. Even though ketamine and Spravato, I bring these treatment options up, they're not psychedelics in the classical sense, but they do have a lot of similarities that we can draw on. Our clinics focus on offering these treatments in a very safe and secure way, and trying to really champion access to care for those in need. There's definitely a major mental health crisis nationally as well as Illinois, especially with first responders, veterans, and many who are waiting for this treatment. The traditional treatments that are around, we utilize them in our practice, but there are some shortcomings and some limitations. For example, if we look at just traditional antidepressants, one is their overall efficacy and remission rates are really low. According to the STAR-D study, which is a major landmark research study in psychiatry, it showed that only 37% of patients achieved remission on their first medication trial. But even more alarming is that each successive medication trial that there is, the rate of remission goes down. By the third medication trial, it's down to 14%. That's really not acceptable when you think of somebody who is suffering and waiting for a treatment that they need, and they try another medication and another medication and not get the results. The odds of having another depression episode go up with each successive med trial. The rates of adverse effects causing them to stop the medicine, that rate goes up with each successive trial. So, and there's also the element that those traditional medications, they can take weeks to really become effective. Seeing firsthand patients who have seen some relief after even the first treatment of psychedelic-like compounds gives that glimmer of hope and light to keep them going and get them, basically feel like there's the hopelessness. We can see that dissolve really quickly, even with just a glimmer of improvement after one treatment. So that is one of the major differences. Psychedelic medicine work in a completely different manner than traditional meds. When we look at psychedelic medicines, they really have two prongs of how they approach treatment. One is a psychological benefit and one is the medical benefit. When we look at psychological benefit, due to the psychedelics causing an altered state of consciousness, allows you to look at your previous trauma or yourself from a new light, especially when you're pairing that with psychotherapy from certified psychotherapists who have been trained in leveraging this medication and offering it in an environment where safety and screening and follow-up are paramount. We have seen that somebody can reframe their trauma by being able to look at it from a new angle and get to the root conflict that's driving substance use, driving the depressive symptoms. Many times there is a root psychological conflict where traditional medications just never get to the bottom of. They provide some symptom relief, and that's good for some patients, but all patients are different, and there are some where the traditional medications won't be enough. Then on top of that, there's a medical benefit as well, which is the neuroplastic state that psychedelics cause. They alter the neural connectivity, they quiet certain regions of the brain, the overactive regions that have a lot of negative self-talk, and they allow the patient's brain to be in a more malleable state and rebuild some of those neuronal highways. That's another major difference in the way psychedelic medicines work. Most new and novel treatments that are being studied now in psychiatry are not looking at the previous 30 years, that approach of just looking at certain neurotransmitters. They're really looking at this junction between psychological and medical benefit with an altered state of consciousness, looking at the brain's ability to become malleable, and that state allows somebody to make change. I have, in my practices, I utilize ketamine and Spravato for the appropriate patients, but every patient's different, and for some, they may need a different treatment option, such as psilocybin, for example, which can actually have longer durability of benefit. When we see that, one of the differences of traditional meds is you take it every day, and sometimes you have adverse effects that you just suffer through day to day, whereas with most of the studies for psychedelics that have been done have really been focused around, 1, 2, or 3 dosing sessions, and those dosing sessions are sandwiched with a lot of support and psychotherapy surrounding it. And that limits the exposure to the medication, but also improves outcomes tremendously. We have also seen that in patients that are receiving these medications, like psychedelic medications, there can be a real shift in their overall prognosis, just being able to make changes in their behavior make changes in their thought patterns. There are a lot of research studies out there that support and show efficacy of these medications. The number of studies has exponentially increased, especially over the last 5 years. There are limitations in studying psychedelic medicines that I definitely don't want to discount. It's hard to sometimes design research studies where it's appropriately blinded, where the patient doesn't know whether receiving psychedelics or they usually can tell when they received it, so they call that functional unblinding. However, when you zoom out and look at the body of research, and then you look at what the real life evidence support for any practitioners that already work with this medication, the efficacy, the speed of its effects cannot be ignored. And there are many patients who are wanting and needing this treatment because they have failed many other treatment options. This could be the difference between life or death. It's very important as an addiction psychiatrist that I understand that all medications, there are a lot of medications that can cause negatives. When you compare, such as the opioids that are already available for pain relief, or even illicit substances like cocaine or other anxiety meds like benzodiazepines, these medications can actually cause physical and withdrawal symptoms and have a very negative outcome. Whereas it's been shown that the healthcare costs related to an overdose, there's really no overdose data on psychedelics. There's a refractory period after a dosing of a psychedelic where somebody does not typically exhibit increasing amount of use every day and get to a point where they're physically dependent and have withdrawal symptoms. We don't see that with psychedelics. So it's a bit of a misconception that psychedelics kind of are quote unquote addictive. Yes, anybody using psychedelic in an unsafe environment, I believe in regulation and bringing this to appropriate practitioners that are in an appropriate setting for appropriate patients. And when you put that together and provide this treatment in the right way, it can be done safely and securely. So thank you very much. I appreciate the opportunity to speak today.
Thank you so much, Dr. Nazeer. You being a practitioner that is actively prescribing ketamine and Spravato is an important voice today, so I appreciate you being here.
Thank you.
Next, hopefully tech is working, although I know we are actively working on the video issues. Tim Spalla, are you ready and can we hear you?
Yes, ma'am. I'm here.
Excellent. Thank you so much. Before you get started, I just want to note that Representative Amy Grant is here with us virtually.
Great.
Take it away, Tim. Thank you so much for being here.
Of course. So anyone who may know me, brevity is not my strong suit, so I'm going to try to stick to this because I know our time is somewhat limited today, but so I'll start out by saying good afternoon, Chairperson, representatives, and members of the committee. My name is Tim Spalla. I'm an Army combat veteran, a former National Geographic wildlife crime investigator, a Pat Tillman scholar, and a licensed therapist here in Colorado. But most importantly, I'm the proud father of two wonderful little boys. And I'm honored to be here today to speak in support of HB1. My testimony is both deeply personal and clinically informed, shaped by my own healing journey and my research and work with veterans, first responders, and others. Psilocybin-assisted therapy helped save my life. It also helped me find the will to pursue what I believe is my true calling, including founding the Wounded Healer Project, which is a 501c3 nonprofit providing pro bono mental health services to justice-involved veterans here in Colorado, and pursuing a doctoral degree in clinical psychology from the University of Denver. Today, I hope to convey why psilocybin-assisted therapy should be considered as a treatment option, not only for people like me, but for all of those struggling with behavioral health challenges, and why Illinois has an opportunity to help lead the way in helping to transform mental health care both in the state and around the country. During my time in the military, I served as an Army Ranger intelligence specialist, completing multiple deployments to Iraq between 2006 and 2009 at the height of the insurgency. Following active duty, I spent several years as a private military contractor supporting special operations counterterrorism missions throughout Africa, the Middle East, and Europe. These experiences were marked by extraordinary pressures, moral conflicts, and exposure to levels of violence and human suffering that cut far deeper than I had realized at the time. For years, I struggled not only with the weight of PTSD, but also with something that had remained hidden from me. What I eventually came to understand as moral injury, as Drew mentioned earlier. This is a wound that occurs when our actions or inactions clash with our most deeply held moral beliefs. It wasn't just about what I had witnessed or experienced, or even what I had done or failed to do. It was also about the person I had believed I had become because of all of it, and the never-ending questioning of whether or not that person could ever be forgiven. For nearly 15 years, shame and guilt consumed me, fueling a relentless cycle of self-hate, addictions, insomnia, suicidal thoughts, and an overwhelming sense of isolation. These struggles seeped into every corner of my life, far beyond the fields of conflict overseas. Like many of my fellow veterans, I eventually returned home to find myself trapped in a toxic marriage, only deepening my feelings of aloneness. I struggled to connect with my two young boys, relate to others, or find any sense of meaning or purpose in a life that I no longer wanted to live. When I turned to the VA for help, I was diagnosed with PTSD, depression, and alcohol use disorder, among other conditions. While prescription medications and talk therapy provided some relief, they couldn't touch the deeper wounds I was carrying. These treatments focused on managing symptoms, and while they did help keep my body alive, they couldn't address the all-consuming belief that I had fundamentally failed as a person. And so I struggled to fully articulate the depth of my suffering, and in truth, I doubted whether the system was even equipped to address it. In the mental health counseling field, we often hear how traditional talk therapies can fall short of reaching the profound wounds caused by experiences that lead to things like PTSD, addiction, and moral injury. For veterans like me, this gap in care often leaves us feeling unseen, unsupported, and without hope. By 2018, I had reached the lowest point of my life. Nothing I was doing to fix myself seemed to work. And late one evening in my home in North Carolina, it became clear to me that I couldn't take it anymore. I had a plan, means, and the courage to put an end to the nightmare I was living, and if it had not been for my infant son waking up in the exact moment he did, I wouldn't have made it here today to share with all of you my story. This experience served as a wake-up call, a profound catalyst revealing reasons for me to search for another way. I began researching alternative therapies and came across studies on psilocybin. Initially skeptical, and after years of reading, watching, and listening to other stories, in 2020, after relocating my family to Denver, Colorado, I eventually gave it a try. While psilocybin couldn't save my broken marriage, it did save my life, and it helped me become the father that my little boys deserved. It helped me put the shattered pieces of my story back together in a way that felt more aligned with my soul's purpose on this earth, and it gave me a chance to transform my pain into a mission to help others. But most importantly, working with this medicine helped me discover a newfound capacity for a genuinely felt sense of self-love, self-forgiveness, and self-compassion for all the suffering that I was meant to endure in this life, and the person I became because of it. As a mental health professional and natural medicine advocate, I have witnessed the transformative power of psilocybin-assisted therapy for veterans, first responders, professional athletes, and others who feel trapped by their past experiences and negative self-beliefs. Many of these individuals have tried everything the system has to offer, only to remain stuck in self-destructive patterns and despair. Psilocybin-assisted therapy has been a game changer for many of them, just as it was for me. Research published as recently as 2023 has shown that psychedelics like psilocybin promote neuroplasticity through their unique ability to enter neurons and activate intracellular serotonin 2A receptors, which play a key role in mood regulation, perception, and cognition. Upon reaching these internal receptors, psychedelics like psilocybin trigger molecular changes that help enable the brain to form new neural connections, neuroplasticity, and thereby creating opportunities for individuals to overcome maladaptive behaviors and adopt healthier emotional and cognitive patterns. Furthermore, research studies going back as far as 2011 and earlier have indicated that this process can also work to help reduce the symptoms of depression, anxiety, addiction, and trauma-related disorders while fostering a greater adaptability and resilience. For individuals with PTSD, several studies from 2015 through the present reveal psilocybin's multifaceted therapeutic potential. At a neurobiological level, psilocybin reduces hyperactivity in the amygdala, the brain region responsible for fear responses that is often dysregulated for those of us struggling with PTSD. This decreased amygdala activity allows patients to engage with traumatic material without becoming overwhelmed by their typical fear-based responses. Clinical studies indicate this combination of neural rewiring and enhanced emotional processing helps people move from avoiding trauma towards accepting and integrating these experiences by incorporating new perspectives and with a greater sense of self-compassion. Beyond symptom relief, psilocybin facilitates profound states of awe and wonder and connectedness that can help address different types of psychological suffering. For those struggling with moral injuries and their accompanying feelings of disconnection, guilt, and shame, recent studies show psilocybin-assisted therapy can help facilitate a deeper level of forgiveness, self-forgiveness, and acceptance rarely achieved through traditional therapies. This transformative potential extends to other forms of existential distress as well. Research published as far back as 2016 has found that psilocybin-assisted therapy can reduce anxiety and depression in cancer patients and others struggling with terminal illnesses, while significantly improving their sense of purpose and quality of life. These distinct but complementary findings suggest psilocybin may be uniquely capable of addressing both acute psychological symptoms and deeper spiritual and existential challenges. In summary, as both a veteran and a therapist, I have seen how psilocybin-assisted therapy unlocks the doors to healing by promoting emotional resilience, fostering deeper connections, and transforming lives. For those who feel trapped by trauma, addiction, and other mental health challenges, this therapy can offer a way out and a way forward, a chance to reframe their stories and rebuild their lives with hope and purpose. The existing and emerging body of research underscores what I have experienced and witnessed firsthand. Psilocybin is not only a promising behavioral health treatment, but also a potentially life-saving alternative for those of us who feel they have run out of time and options. I know my testimony today may feel a bit rushed, but I do thank you all for your time and attention, and I will be happy to stick around at the end if there's any questions for me. Thank you all.
Thank you so much, Tim, for coming to us from Colorado and sharing your professional and also lived expertise. It's very valuable. We are just grateful you'll be around for questions too. Next, we're going to turn it over to Dr., I believe, Jessica Punzo, who's here in person. Thanks for being here, Dr. Punzo.
Thank you. So my name is Dr. Jessica Punzo. I'm a licensed clinical psychologist. I'm also the president-elect of the 56th Division of the American Psychological Association that focuses on trauma psychology specifically. With that being said, though, I want to acknowledge that the views that I express today are only my own and don't necessarily reflect the APA or the Division of Trauma Psychology. It's really a great honor to be here today to talk about this discussion on the future of psychedelic therapy in Illinois. There's so much to say on this topic, but I don't want to take up too much time. And I could probably fill my time here with giving you a bunch of research data and statistics on the efficacy of psychedelic-assisted therapy. But instead, I want to speak from my heart and my lived experience as a trauma psychologist in the front lines who's been practicing for almost 15 years. I've worked in a variety of settings treating trauma, from prisons to jails to community mental health centers to the VA and various outpatient settings. I've worked with all sorts of survivors with different traumatic experiences and symptom presentations. I've been trained in and utilized various evidence-based treatments for PTSD. And while these treatments can be very helpful, the reality is not all individuals are going to respond to these type of treatments. And the harsher reality is that many survivors continue to die by suicide each year due to their PTSD symptoms. Unfortunately, sometimes traditional therapy is just not enough to break through years of PTSD symptoms and traumatic stuck content. Moreover, the few medications that have been approved to treat PTSD only treat a small portion of the symptoms, leaving the vast majority of PTSD symptoms unresolved. In my private practice, I typically see clients who have complex trauma histories and don't fit neatly into a DSM-5 criteria for PTSD. These clients often have years of childhood abuse that gets compounded by trauma in adulthood. Years upon years of compounded abuse simply cannot be solved in 12 sessions. As Dr. Judith Herman once wrote, complex trauma requires complex treatment. And the unfortunate reality is that many clients with trauma histories have experienced multiple failed treatments and are desperate for new treatment options. Therefore, we really need to start thinking outside of the box and reimagine what comprehensive treatment can look like. We need to be open to exploring novel treatments and promising approaches, one of those being psychedelic-assisted therapy. I personally got trained in psychedelic-assisted therapy because I wanted to be able to offer another option for my trauma clients. Psychedelics have the potential to enhance, assist, and accelerate our already established empirically supported treatments. As part of my training in psychedelic-assisted therapy, I was granted the opportunity to take psilocybin in a therapeutic setting as an experiential learning opportunity, both being a client and a therapist. And Drew, who is on the call, was actually one of the facilitators in that program. This was one of the most profound therapeutic experiences in my entire life. Not only was I able to experience powerful healing for myself, I watched dozens of my other group cohort members experience a powerful, similar experiences. And almost a year later, that experience lives vibrantly in my heart and in my mind, and I still keep in contact with many of those members. And I have heard countless other stories like mine of how psilocybin has changed people's lives in even just a single dose. I do believe that with the proper training and oversight, psychedelic-assisted therapy has the potential to change the field of psychology and how we treat mental health conditions, especially PTSD. While this treatment will not be for everyone and will not solve all mental health issues, it should be an option for appropriate candidates. The bottom line is that those with mental health issues deserve better. They deserve more than what they've been given, and they deserve hope. And we, as providers, researchers, government officials, policymakers, have a responsibility to do our part in advancing new and promising treatment options for them. Thank you so much for your time.
Thanks so much, Dr. Punzo. Very much appreciate your testimony. Next, we are going to turn to Dr. Holden. Introduce yourself and take it away, Doctor.
It's on. It's red. It's on. You just won't see it.
Oh. Good afternoon, Chairperson and Representatives. My name is Chris Holden. I'm here to speak on behalf of myself and the Illinois Psychiatric Society, and I should say that my views, or that I'm about to express, are my own and that in the Illinois Psychiatric Society, and not my places of employment. So I am an assistant professor of clinical psychiatry at the University of Illinois, where I'm also the director of addiction psychiatry, as well as the program director of the Addiction Medicine Fellowship, where we train physicians who are the next generation in addiction medicine professionals. I also work over at the Jesse Brown VA, where I'm the medical director of our residential addiction treatment program, where we treat veterans with severe substance use disorders in a residential addiction treatment setting. I am board certified in psychiatry, addiction psychiatry, and addiction medicine. And I'm here to express concern about any sort of legislation that would deregulate psilocybin or any sort of other hallucinogenic substances. Psilocybin is a Schedule I substance under the Federal Controlled Substances Act. Schedule I drugs, which include heroin and LSD, have a high potential for abuse and serve no legitimate established medical purpose in the United States. Legalizing the medical use of psilocybin precedes evidence about its safety and efficacy. Research is underway on psilocybin for the treatment of depression and PTSD, and it has sparked interest in its potential. But the results are not yet conclusive. Importantly, we do not know enough about psilocybin's dosing limitations and guidelines, interactions with other medications, efficacy within a comprehensive treatment plan that includes therapy and other supports, and its short and long-term side effects. We have strong evidence-based ways of treating depression and other mental health conditions that should be considered before hallucinogens, including psilocybin, but they are often underutilized or not fully utilized. These include therapy, medications, and combinations of those. Most psilocybin research protocols require use under the supervision of a physician, in part because hallucinogens can have significant immediate health and psychiatric impacts, including changes in perception, such as hallucinations, intense emotions like intense anxiety or dysphoria, increased heart rate, blood pressure, respiration, temperature, and in rare cases, paranoia and psychosis. Less than half adults in the U.S. with any mental illness receive treatment. And I should say, as headlines and industries tout treatments, the general consumer may seek that substance to find relief. It is important to not get ahead of the science, research, and guidelines, whether it be with psilocybin or any other similar substance, particularly if it may be associated with a substance use disorder. Although I am hopeful about the potential for new treatments that can help with mental health, I am wary of clinics or companies that offer psychedelics that are not FDA approved, especially without a psychiatrist involved and without more research. There is currently inadequate scientific evidence for endorsing the use of psychedelics to treat any psychiatric disorder except within the context of approved investigational studies. The Illinois Psychiatric Society, American Psychiatric Association, and the American Medical Association support continued research and therapeutic discovery into psychedelic agents with the same scientific integrity and regulatory standards applied to other promising therapies in medicine. Clinical treatments should be determined by scientific evidence in accordance with applicable regulatory standards and not by ballot initiatives or by popular opinion. The FDA has not yet approved psilocybin for any medical condition. While the FDA has granted psilocybin breakthrough therapy status, this merely establishes the process by which to further study this treatment in a medically supervised setting. This status does not signify safety or legality. We need to follow the science and clinical guidelines properly to realize the benefit of these potential therapeutics safely. Some hallucinogens are approved for research via the FDA Breakthrough Therapy designation, but the therapeutic indications are narrow and with highly structured protocols and expert healthcare providers. Dispensing these drugs require involvement of someone with medical training. We also need to consider long-term effects of the use of the medications in these protocols. The Illinois Psychiatric Society cannot support a state systems of licensing and regulating psychedelic therapies before FDA approval. We urge the legislature to defer any bills related to psychedelic treatment until the FDA and the broader medical community have hard evidence on efficacy and develop adequate standards of care, such as dosing, prescribing, treatment protocols, and packaging. Thank you very much.
Thanks so much, Dr. Holden. I just want to get clarity of something you said at the beginning because I didn't hear it right. Are you testifying in your capacity as a leader with the Illinois Psychiatric Society?
Yes, I am.
Okay, excellent. I just didn't catch that. So thank you.
Yeah, just not at the University of Illinois, or in particular at the Jesse Brown VA.
Understood. Good to clarify that.
I did not ask for permission about that.
Excellent. Thank you for clarifying. And thank you for your testimony. Next, we're going to turn to MicKensy Ellis-White. Take it away, MicKensy.
Good afternoon. Thank you for the honor of allowing me to be here to testify in front of your committee today. I am a licensed clinical professional counselor in private practice in Danville, Illinois. I'm also a master addiction counselor and certified psychedelic assisted psychotherapist. I was trained by the Integrative Psychiatry Institute in 2023, where I was able to learn from some of the facilitators, such as Drew. He was one of my facilitators as well, and Tim Spalla, who already testified on moral injury. Apart from that, I'm also a veteran of the Iraq War. I went to Iraq in 2011, where I served as a behavioral health specialist, working in detainee operations. When I returned home, I worked at the VA as a licensed clinical professional mental health counselor in substance use treatment for 8 years. It is my testimony today that psilocybin has personally helped me in my journey as a clinician, and it is my life's work and passion to work in this industry and helping my fellow veterans in this capacity. I will say that psilocybin comes from a psychoactive substance found in over 200 varieties of fungi. It has been used in indigenous populations for literally centuries. It's been most well notably treated and has the strongest evidence for major depressive disorder, existential distress associated with serious illness, anxiety and depressive symptoms in cancer patients, alcohol use disorder, obsessive compulsive disorder, eating disorders, migraine headaches, and substance use disorders such as cocaine and opiates. One study, in fact, found that 60 to 80% of participants reported sustained treatment effects 4.5 years after their treatment. Some studies have shown a substantial therapeutic benefit for major depressive disorder comparable or greater than standard medications such as Lexapro. I would also like to point out that there have been no new approvals for FDA-approved medications since 1999 for the treatment of PTSD. The only two medications that are currently indicated for PTSD at this time are sertraline or Zoloft and paroxetine or Paxil. Other medications can be used off-label, but to his point about FDA approval, we are still waiting for more medications to come online. As far as the safety profile of psilocybin, it is shorter acting than LSD with less cultural and political stigma. There's less chance of adverse reactions than LSD. It is non-toxic, physiologically well tolerated, and suited for use in terminally ill patients. So some of the positive effects that you might experience in a psilocybin journey include reduced depression, reduced anxiety, improved quality of life, meaning, optimism, increased synaptic plasticity, ineffability, which is too great or extreme to be described in words, low physiological toxicity. It is not associated with compulsive drug seeking. People often report finding personal meaning, spiritual significance, increases in well-being, and it lowers psychological armor, speaking to the perspectives of some of the other people that have testified today. There are some adverse effects. Those include altered consciousness, such as visions, auditory distortions, and ideations, altered mood, such as sad or fearful or irritable, distorted sense of space and time, panic, confusion, paranoia, feelings of losing sanity. It can produce acute and rarely persisting adverse psychological reactions, individuals putting themselves at risk for physical harm, but that is often seen in uncontrolled environments and not the ones in which we are speaking about today. Synesthesia, which means sensory crossovers. An example would be tasting colors. And nausea and heart palpitations. There are contraindications, which include avoid taking cannabis, alcohol, NSAID pain relievers, opioids, stimulants, muscle relaxants, and sedative hypnotics for 48 hours prior to dosing. Taking antidepressants or antipsychotic medications with psilocybin can cause severe headaches, heart palpitations, agitation, nausea, vomiting, and sweating, and psilocybin is much less effective when you are taking some of those drugs. Additionally, benzodiazepine use requires a consultation with a doctor and can hinder the effectiveness of psilocybin. Ingestion of any other psychedelic medication within 7 days of dosing is also a contraindication. I will say that from my personal experience going to Oregon and receiving this medication, it was very well controlled. They do have an excellent paradigm for us to work from, and I think that it would be very beneficial, especially speaking to the fact that I am from a rural area in Illinois that is underserved, and I actually have a VA facility in our town, and we are losing providers, and we do not have a lot of effective treatments that are really helping our population. So with that, I will close, and I look forward to answering any questions that I can. Thank you.
Thank you so much, MicKensy. Thanks for being here all the way from Danville. We really appreciate it. Okay, with that, we are a little behind, but we're going to get started with Q&A. I'm looking around the physical room and looking around the virtual room. I see Representative Tipsword. Take it away.
Thank you, Chair LaPointe. Appreciate it. I want to start out by saying this is my first trip with this laptop, and I can't get my camera to work, so I apologize for that. I have a couple questions, and I guess for any of the panelists. The first would be, can someone describe for me the setting where this would take place at? First of all, I'm assuming a clinic of some kind, and also knowing that this journey, as it's been described, is kind of an all-day affair. Could someone just kind of lay that out for me, how that would look?
I can take a shot at that question. So, I mean, it should be, first of all, administered I would agree, in a clinical setting. The practitioners that are administering the psychotherapy, so the therapist should be certified in leveraging psychedelic medicines and using that in psychedelic-assisted therapies. There should be appropriate equipment in that clinic for monitoring blood pressure, heart rate, oxygen saturation. So it's a very controlled clinical setting. Like in our current clinics that we leverage IV ketamine, which is a lot shorter. You're correct that psilocybin could be a lot longer of a dosing session, typically with 1 or 2 therapists there for that session. In our practice, we believe in safety as utmost importance, so we always require a medical provider also be on site as well, and the involvement of a psychiatrist. So it would be done in an outpatient clinical setting with the appropriate treatment team.
Okay, I appreciate that, and that was going to lead to my question of, is a physician on hand during this time, so I appreciate you getting to that. Secondly, another question, I've kind of heard it, I think, but how many doses is typically used in this situation? I've heard someone said as few as 1. I'm wondering, is it an ongoing maintenance, or is it kind of a 1 or 2 and done kind of thing?
So I can, this is Tim Spalla. I can weigh in on that one, just as we're out here in Colorado. So there's a lot of different ways of approaching this, but it's one of those things where it is kind of person dependent. And ultimately it's really, what are we trying to work on? Here in Colorado, of course, you guys are aware, we have the decriminalized legislation that was passed in 2019 here in Denver, and then in 2022 in Colorado statewide. And what that ended up creating in advance of the regulated system, we live in an environment out here where personal use, production, sharing of psilocybin and 3 other psychedelic compounds are decriminalized. And so the situation that's created out here for folks is we can't So there's no monetary exchange. Everything can be grown, gifted, and given away. And what often happens is the preparation and the integration and the harm reduction are services that can actually be monetized. However, the actual medicines can't be. And what you find is it really depends on what someone is showing up with. As Dr. Punzo mentioned, a lot of, I talk about veterans a lot. I talk about first responders and that high trauma population, but a lot of what we see out here, at least I see personally, is childhood trauma. That's not something that just gets resolved with one psychedelic session. For some of us, if we're lucky, it will. But there's more to the work than just taking, ingesting these medicines. There is, weeks of preparation, weeks of working on what is the intention for the ceremony or the psychedelic journey, really honing in, what is getting in the way of working on that in a non-psychedelic state. You work through a lot of that stuff. You create an environment where the set and setting are established. So once you've done the build up, the preparation work, you go into the ceremony, which could last, depending on dosage, anywhere from 3 to 5 hours or longer. If it's a higher dose, a lot of that just depends on body weight and other factors that you weigh in. And then the integration period afterwards, which I tell people is really the most critical phase of the entire thing. You can do as much medicine as you want, but if you're not doing the work to actually integrate what you're experiencing in these really kind of big and expansive psychedelic sessions, then it's like any other therapeutic treatment. It'll have some limiting effects, but it's likely not going to last all that long. And I have seen folks, I work with a lot of combat veterans from special operations world, and some of them will come in and have, one therapeutic dose session with psilocybin, and then that's it. Like there's never a calling to ever go back. And then there's others who it's going to take a couple of different therapeutic sessions and the prep and the integration in between to really get a handle on what this thing is and try to resolve it. So it's really fluid. There isn't any really one set standard of you just do one and all of a sudden everything's better. But I hope that answers the question.
It does. It kind of begs a lot of others, but for the restraints of time, I have one more quick one, and this would be for those folks who are on this for a prolonged time. As Dr. Holden pointed out, this is a Schedule 1. Schedule 1s are highly addictive. What's our worry about that moving forward? Or is it those folks, you folks who are on in favor of such a thing, do the benefits outweigh the risk of addiction, I guess? And that'll be my last question. Thank you, Chair.
I will say in the 2 years, this is Tim Spalla again, in the 2 years that I've been working in this field, I have not seen one instance of anyone becoming addicted to psilocybin. As a matter of fact, it's just the opposite. When you're done, you're done. I have never heard of or seen personally or read any kind of research out there that indicated someone became addicted to psilocybin. And I'll stop there.
I would second that. This is Richard Drew Snyder in Oregon. In the hundreds of people that I've facilitated with psilocybin, I've never seen any potential for addiction. And actually the body rapidly builds up a tolerance to psilocybin, so it's impossible to get addicted. There's an incredible amount of safety that has been found with psilocybin compared to any other substance, whether illicit or controlled. And I think that it's unfortunate that it is Schedule 1 because there is therapeutic potential and there is no possibility of addiction with mushrooms.
Dr. Holden, I think you want to chime in.
I just want to concur with what's been said. I do have concerns, but as far as the addictive potential for psilocybin, it's relatively nil. So I just want to agree with what's been said.
Thank you for that. Should we move to the next rep for questions? Rep Tipsword?
Yes, thank you, Chair. That's all I had.
Excellent. Okay, Rep Howder.
Well, thank you very much, Chairperson LaPointe. I have a few questions, mostly for Dr. Holden. Dr. Holden, you may or may not know, I'm also a physician, and I was particularly interested in what you had to say. I would just like you to explain to the committee just what a psychiatrist is and how it's different than other mental health professionals and their abilities and their education experience and their licensing. Can you do that for us?
I'll do so as briefly as possible. So a psychiatrist is somebody who got their undergraduate degree and then went to medical school, just like any other physician, and then became a physician and they got their medical degree or their MD or their doctorate in osteopathy, so their DO or the MD. And then basically after you finish medical school, you go into a specialty. So that can be internal medicine or family medicine or pediatrics. And this is a residency or psychiatry. And the residency can last anywhere from 3 years in duration to probably like maybe 5 or even 6 years. And that's where you get your specialty training. After medical school, after you get your medical degree, I chose to become a psychiatrist, and I went to a psychiatry residency where I did 4 years of specialty training in psychiatry that included a lot of medical training. We're learning to really understand medical illness and what have you, and then kind of parallel to that, and then serially in addition to that, got more training and learning to understand mental illness, but always kind of through a medical lens, basically. I could go on, but trying to be mindful of time.
Yeah. So thank you for that. But specifically, when I tried to describe a psychiatrist, I say they're a medical doctor that's able to treat mental health disorders with medicine and medication. Are there any other professionals in Illinois that are licensed to treat mental health conditions with medication?
There would be psychiatric nurse practitioners.
Okay.
There are also psychologists who have prescription privileges in the state of Illinois to prescribe psychotropic medications.
Okay. So when this situation, and I heard Representative Tipsworth's question, but I didn't hear the answer, is in this bill, would only those who are able to prescribe medications currently be able to administer psychedelic medications?
Thank you for that question, Rep. Howder. This is Chair LaPointe. I just want to say that we're going to hear in depth about the bill from the bill sponsors in the third panel.
Okay.
I just recognize these panelists are not necessarily experts on House Bill 1.
Oh, okay. So in your understanding, I just wanted to, again, just clarify who would be able to give out these medications, and I wasn't sure of the answer to that question.
We can just hold that question till people are on the witness stand. We will not forget it. It's a good fundamental question.
Okay. So, Dr. Holden, I'll just have a series of very quick questions, maybe quick answers. Just again, in your opinion, would it be accurate to say that there's not enough research behind this medication for it to be approved?
Yes.
Do you think the evidence so far, the studies that have been done, are inadequate at this time?
Yes.
There is no FDA approval, and this is, in fact, an illegal substance?
Yes.
Do you believe it's accurate to say that there's not enough safeguards for patient safety?
Yes.
Are you concerned how it would be administered, and those administering would not have the proper education, expertise, training, and experience to handle and administer these medications?
Yes.
Are you concerned about the complications that may occur?
Yes.
Is that why the Illinois Psychiatric Society is opposed?
At least in part.
Okay. So, and many times, you know, that in medicine, we're trying to treat patients, and I see the potential in this, and I desperately want this to help people, but we have to go through the process. And in my opinion, I have heard so many times, and I've been a great advocate. I've tried to be a great advocate for mental health care, and said again and again, mental health care is health care. But when we come and we try to approve an illegal substance without enough evidence, creating a licensing system for I don't know who will be administering this medication and treatment, it's not FDA approved, and then we complained that mental health care is not being treated like health care. You know, it just frustrates me, because we don't want to go through the process that it takes. I want this to work. But in medicine, we cannot have emotion rule over evidence. And so I just urge the committee to see the potential and then go through the process. Thank you very much.
Thanks, Rep. Powder. I think we have like 2 or 3 more questions. I'm just going to chime in with some comments here. Okay, so we have me, Rep. Haas, and Rep. Costa Howard. I'll hold my questions, but I just want to say a few things. That was helpful for everyone to be reminded what the educational pathway of a psychiatrist is. I just want to note there's 2 psychiatrists sitting in front of us on the witness stand, and they feel differently about this issue overall, and I'm sure you 2 are a microcosm of all the psychiatrists all around the country. And just thanks to Tim for pointing out, in terms of what Colorado has done, there is a long runway to get to the regulated access component of what we are talking about here. Colorado started with decriminalization, although as he said, you can't exchange any money as related to psilocybin, and then everything is kind of moving at a incremental pace. So Colorado is on track for regulated access, where people could access, it might just be psilocybin, through facilitation. So we are going to hear more about what the bill is in Illinois, and so that was a little awkward because we don't have those answers until Senator Ventura and Rep. Ford and IPS come up, but we will get there. Okay, I'll hold my question and turn it over to Rep. Haas, and then we'll go Rep. Costa Howard.
Thank you, Rep. LaPointe. I think my questions will probably be geared toward Drew. You spoke about being a facilitator. Can you speak more about what actually is a facilitator? How does one get a facilitator license and qualification, and how are they regulated?
Yes, in Oregon, we have a non-medical model, and so the pathway to become a facilitator was deliberately left open to allow people from many different backgrounds, especially people who have not been able to follow like a traditional background but are healers, but they still have to go through a very regulated process of training in order to become licensed psilocybin facilitators. And so there are psychiatrists and psychologists and psychiatric nurse practitioners who are psilocybin facilitators in Oregon. There's also therapists and people with less education who have gone through that training. And one of those training programs I am a part of. It's a year-long training program at the Psychiatric, now I'm drawing a blank and I'll come back to that. The Integrative Psychiatry Institute. And that program is only for psychologists, psychiatrists, psychiatric nurse practitioners to become psilocybin facilitators. Colorado has a different program. They have different tiers of licensure and what is allowed in the facilitation of psilocybin. And I think that, as we look at, again, the safety of psilocybin, and over the year and a half that Oregon has been doing it, I have not seen any issues with, people administering and facilitating people taking psilocybin. But the thing in Oregon, go ahead.
My question was, so they're regulated by whom at the state level?
The Oregon Health Authority.
And how many states are you aware of that have this type of licensure?
Oregon and Colorado.
Okay. And then speaking to a couple of the panelists here, the two women on our panel, you both indicated that you're licensed as well. You've gone through these programs?
Yeah, so there's a little bit of a distinction that I think needs to be clear here, that I'm a licensed clinical psychologist, and since we explained what a psychiatrist was, I think it's fair that we explain what a psychologist is, because we go through almost exactly the same training, but in a clinical psychology degree. So we get a doctorate in clinical psychology, which is 4 years after undergraduate, and then an advanced fellowship after that. So I just want to make that distinction as well.
Well, but a psychiatrist is a medical doctor.
It's a medical doctor.
Clearly not exactly
we are
the
a
same
doctor
kind of
in
training.
psychology, and what we're talking about here is a large piece of all of this. The integration and the preparation is done by therapists primarily. So the bulk of the work that is being done by clinical psychologists.
So back to my question, the two women that are sitting here, yourself and the young lady next to you, indicated that you're licensed in this same program that Drew spoke of, correct?
So we are certified psychedelic assisted therapists.
Is this a licensure that Illinois currently has? I'm hearing that Oregon and Colorado are the only two that allow for this type of licensure.
No, so the IDFPR is certified, you have your psychology license, and this is like a certificate training, right? So just like you would get certified in EMDR or any biofeedback.
I'm an LCSW.
Yeah.
So it's practiced for twice as long as you have. I understand that. So this is not a licensed medication in Illinois, correct?
Correct.
But you're telling us that you're allowed to prescribe this in Illinois?
No, I did not say that. I said that there are certain psychologists who have prescription privileges for psychotropic medication, not psilocybin. And I am not one of those people, but there has been legislation that has gone through Illinois that has allowed psychologists to receive extra training in psychopharmacology to be able to prescribe psychotropic medication. But no, psilocybin would not be one of those.
Correct me if I'm wrong. I'm hearing the two of you say that you were licensed in prescribing this and are both practicing in Illinois.
No, we're not licensed in prescribing anything. We're licensed in
administering.
Psychedelic assisted therapy. So the therapy component, we're still working under our scope of practice, which is therapy, providing therapy.
Okay. So there's someone else in your practice who is prescribing?
It's not legal here in Illinois, so no.
So how is this, how are you effectively then doing this treatment if the medication is not being prescribed to the clients that you're treating?
Well, we're not. I think that's what we're talking about, where the bill is to get to a pathway to be able to do that in Illinois. I think, Abid, maybe you could speak about ketamine, which is a similar format, and how it works with a prescriber and a therapist.
Right, so I would agree with Dr. Punzo that there's
I'm going to jump in really quickly. Going down the ketamine track might not be responsive to the question, and
correct.
And we are on a tight timeline.
I'm just trying to delineate where it's not legal. Psilocybin
right, correct. And I just want to clarify, because I don't know if I'm the only one that heard that earlier, that it sounded as though this treatment was being provided.
No.
In the state.
Maybe if
just want to
Dr.
clarify that.
Punzo or MicKensy, if either of you could just make a few declarative statements for the record to be extra clear that this is not happening in Illinois at this moment. And just to clarify, we have a licensed clinical practical counselor in front of us and a licensed psychologist. So just a few declarative sentences for the record.
Thank you. I'll be brief. I'm certified to work in as a therapist with people that have taken some of these substances, such as ketamine, but we are not currently practicing with psilocybin, and the same is true of MDMA. However, as part of my certification, I was trained in ketamine, MDMA, and psilocybin. I am not eligible to work with psilocybin because it is not currently legal in the state of Illinois. And so I am not practicing, I am not administering, I am not dosing, I am not working with that medication at all whatsoever. However, I am certified to work and have worked with clients that have been using ketamine, which is legal to work with. When I do that, I have a prescriber that is utilizing and dosing and administering. I am not doing that. So I hope that answers your question.
No, thank you for that clarification.
Yes,
for certain. And again, just to be clear about, Dr. Holden, you may want to clarify as well, just to be clear about the difference between psychologist and psychiatrist. Psychiatrists are medical doctors, and psychologists aren't, even given the fact that there are some medications that you are able to prescribe as a clinical psychologist. So just want to clarify that as well.
Yeah, I don't think I was implying that, and I'm sorry if it came unclear, but I do want to clarify, no, I am not prescribing any substances at all because I do not have a license to do so.
Okay, glad we got that clarity on the record. Rep. Costa Howard.
Okay, thank you. I think I might be able to help clarify this just a little bit more so that the record is clear. You do not hold a license to prescribe medication. However, there are programs, and I believe there's one, it is out of Alexian Brothers. I mean, we do in Illinois have programs that allow psychologists, our PhDs, to become prescribing doctors with certain forms of medication. So that it does currently exist in our system here in Illinois. I'd also like to acknowledge the years of work as a psychologist and receiving your PhD. It is not an easy task, and while we recognize you did not go to medical school, that in no way diminishes your education as a PhD psychologist in this area. So thank you. Thank you for that. And that we do recognize that you are not prescribing, you are not treating, it's part of the certification. I will ask, have you, as part of your training though, did you go and observe or participate in a state that is prescribing or doing that? Could you explain that just a little bit, just so we understand if it came to Illinois, what that could look like?
Yeah, so as I mentioned, both of us went to the Integrative Psychiatry Institute that Drew works at, which gives out the certification in psychedelic assisted therapy. Part of that training program allows us to travel to Oregon and to Colorado. So we have two opportunities to have experiential and training opportunities. So for example, if we're talking about psilocybin, we went to the licensed facility that Drew works at and were able to receive and go through the entire protocol that is in Colorado. Both receiving the medicine and then also being a therapist to practice those skills in sitting with someone else.
Thank you. Dr. Nazeer? Thank you. Yes, I would just like to give you an opportunity to answer the quasi-cross-examination questions that Dr. Howder asked. In fairness, you have a different position, and so if you could, if you can remember what some of those questions were, if you could answer from your perspective, I think that would be helpful.
Sure. Like I said, I have first direct-hand experience working with medicines that are similar, not exactly the same. And I think that we can learn a lot from experiences like that. The concept of administration as well and safety, it's a team. So like Dr. Punzo said, majority of the work is being done by therapists certified. In this psychiatrists, where there's a shortage of us, we can only be so many places at one time. So what we do is we are there for medical oversight, and in terms of the medical safety, monitoring, screening, all that, the actual therapy work is being done by the therapist who's certified. Typically, that's the setup. Psychiatrists can also go get the same training if they'd like for it being an actual psychedelic assisted therapist as well. The concept of what is out there already, when we look at precedents being set, I mean, we have medications, Dr. Holden here, he's an addiction psychiatrist. We have medications like methadone, buprenorphine. These are medications used to treat opioid use disorder. We know that they have negatives being an opioid, but when utilized with the appropriate approach and the right treatment team and done in the right way, it can be life-saving for opioid use disorder. To kind of this concept of psilocybin being Schedule 1, saying it has no medical benefit, I mean, to me, that's an astounding statement. Yes, it's true in terms of reality that Schedule 1, that's the definition, but there are hundreds of studies showing this in real life examples and people whose lives have been saved from this medication. And when we look at things that are already Schedule 3, Schedule 4, such as like, let's say Xanax, the negative impact of Xanax, which is a commonly written medication without any of this regulation, and the amount of deaths it can cause due to its central nervous system depression and overdose. And then you put that into comparison of another tool like psilocybin being available, which is, it's completely on the other end of the spectrum. So I do say that there are a lot of psychiatrists. I'm addiction certified too. I mean, I respectfully would disagree with, and he's not alone as well. There are a lot of psychiatrists who have concerns, and there should be. So safety, where it's done, who administers it. Like there's a precedent for Spravato being the first medication FDA approved. It's esketamine. That's a new kind of approach that causes an altered state of consciousness. They have a very strict REMS program, risk evaluation mitigation strategy program. We all have to register for it. Every patient is tracked. And it's actually quite a supported, safe structure to give that medication and when you're working through a framework like that. So I do believe the benefits far outweigh the risks in this case.
Thank you. Just a brief comment. I think this is, I'll be honest, this is scary for a lot of us. We recognize that the science, the data that is out there there's a lot, and yet there's not a lot, at least in terms of the way the traditional forms of medicine, medical research is done and how it is documented as such. That said, I recognize that this is something that is working for some people, and I think we would be fools to suggest that it's not, and yet we're still have fears about the implementation or what this is going to look like or what the other what ifs that come along with it. But to think that since, well, two things. One, when we say ketamine now, most of the United States has a picture of Matthew Perry. And so to suggest that now we're talking about something and this is what people's common font of knowledge would be about this is going to take a great deal of messaging and education in our society as to what the impact, both good and bad, that type of a drug has. However, to suggest that since 1999, the FDA has not approved another drug to address PTSD is absolutely frightening. And we are not doing a good enough job as a nation to fix this problem. So thank you for bringing this forward. I'll be honest, I'm not really sure where I land on it, but I came today, I have addiction in my family, mental health in my family, and I always wonder if somebody would have had a form of treatment that was different, maybe we'd be in different places today. So thank you.
Thanks so much, Rep. Costa Howard, and this is an educational hearing, and Rep. Haas, thanks for pulling those answers out on the record. I'm going to just ask one question and then we'll go to the next panel, and we're going to have the next two panels come up at once because we did lose one witness. So anyone can answer this and just try to do it briefly. So one of the things I keep thinking about when we're talking about this is how we ensure equity and access. And the main way that we do that, even though we don't do it that well in behavioral health, is through insurance, whether that be commercial, Medicaid, Medicare, and 92% of people in Illinois are covered by some sort of insurance plan. So as we contemplate this, and think about how this might work in Illinois, because this is part of an educational hearing, and folks from other states might have something to say, how do we move forward but make sure we have equity and access? Because this hasn't been spoken yet, but my assumption is that when people access various psychedelic or sort of psychedelic treatments like ketamine or facilitated psilocybin, they are paying out of pocket. And that is really challenging and not in alignment with many of our fundamental values. So can somebody speak to how, as we move forward, we ensure equity in access?
I'm currently.
Hi. Oh, go ahead.
Oh, I'm
sorry.
I am currently in the process of going through the procedures to be reimbursed by Medicaid, and so that has been a cumbersome process. So in one way that we could extend the CPT codes and the reimbursement rates for Medicaid past the 53 minutes and over. So typically I bill $908.37 for a 1-hour therapy session. And so that only encompasses up to 1 hour of treatment. And so working with ketamine, usually that's 60 to 90 minutes during a dosing session. So then having the opportunity to extend insurance reimbursement rates past the 1 hour reimbursement, that would increase access to people that have insurance, and also that extension, if we were looking at a Medicaid model, since therapy is covered under Medicaid, I think they bill at the quarter hour rate, but like just ensuring that those rates are reimbursed up to the amount of time necessary. So if a dosing session for psilocybin is 6 to 8 hours, if that's in fact what we're doing as a therapist, then that would be like ensuring that those rates are covered for that extended period of time. It used to be, and I don't have my facts in front of me, but they recently changed the CPT codes so that it was really kind of capped at that 53 minutes and over. And so that has really been a detriment for mental health therapy as a whole. But like that would also be a pretty big barrier in working with psychedelics for the extended sessions. So that's something that the panel can look at, not only to help with this problem, but that extended therapeutic sessions past just the 1 hour of covered treatment would be something that you could do to expand access throughout the state in every arena. So I would just add that as a suggestion.
The billing codes they exist already, and they're being utilized for all forms of therapy. It's really just a matter of how many units of that can you bill, and I guess that's what we're referring to, that gets capped at that 1 hour. The actual coverage is already there. It's just about making it longer. Insurance coverage is the best way for access to care for this by far, because it is a lot of therapy, and that adds up in cost for sure. So ultimately, if there's a way to basically, it's not reinventing the wheel, it's like bringing a whole new code set here. It's really just about allowing more units of therapy, because ultimately, what are we doing? We're giving psychotherapy, and the psilocybin is assisting it. And there's a medical billing component, but we already have precedents with that with medications like Spravato. I mean, it's basically it's the same codes we use for any other evaluation management. It's the physician wouldn't necessarily need to be billing for 8 hours of the physician time per se, because a physician's available and on site, and you can get that done within that one first E&M code for a physician, but then the rest of the time is really just psychotherapy and being allowed to build more units of it to get more
Okay,
time.
thanks for that clarity. Can you just kind of say yes or no? Everything you just said, that we'll take ketamine, for example, which people are accessing now, but they are paying, people have to pay out of pocket for ketamine at this moment, and it is expensive.
There's Blue Cross Blue Shield Massachusetts, Blue Cross Blue Shield Vermont have released medical policies covering IV ketamine for mental health conditions, even though it's not FDA approved yet. So we're already starting to see that. There's some plans in Utah that are starting to cover it. But you're right. So we try to subsidize the cost the best we can by billing whenever we do evaluation management or therapy. Those are covered services. We can bill insurance for that. We just can't bill for the actual infusion, but it does help us bring the cost down. We would try to use any other manner possible, payment plans, you name it, to try to get this affordable for patients.
Okay, excellent. Thanks so much for that clarity
And if I can-
information.
Madam Chair.
We're going to move to the next panel. So Jean Lacey, you're on the next panel. So we're going to turn over now, and you're welcome to address any of these questions in your testimony. So we are going to have Jean virtually stepping up to the table, Senator Ventura here in person. I know we have Rep. Ford virtually, and then Bruce Sewick, hopefully I pronounced that right. Bruce, are you going to come up to the table too? So just for clarity, what we're doing is combining the last two panels here because Gregory Hake is not available. So the intention was to hear from Jean Lacey and then Bruce and then the elected officials. So if it's okay with Senator Ventura, should we just move forward like that? Okay. Take it away, Bruce.
Thank you very much. I appreciate the opportunity, Chairman LaPointe and other respective legislators. It's also an honor for me to represent a plant that has been healing for centuries, something we need to keep in mind when we're talking about FDA models and something. This has been in use by indigenous cultures for centuries with no bad effects, so just something to keep in mind. So my name is Bruce Sewick. I'm a licensed clinical professional counselor with an addiction certification. I've been working in the field of mental health and substance abuse treatment for almost 30 years. I am the retired CEO of Leiden Family Service, a community behavioral health center, and the SHARE program, an inpatient substance abuse treatment center. I have had extensive experience working with clients in need of mental health and substance abuse treatment and want to express my support for the CURE Act. The COVID epidemic made this country aware of the large number of people needing mental health and substance abuse treatment. A National Institute of Health meta-analysis concluded that suicidal ideation and suicide attempts were more prevalent compared with the pre-pandemic period, especially among the adult general population and clinical patients. Considering the heightened suicide risk factors, such as mental health problems and economic vulnerability during the pandemic, large-scale suicide screening for the public and timely intervention programs for high-risk groups are highly needed. The continuously changing pandemic underscores the importance of ongoing monitoring and surveillance for suicidality. Drug overdoses also increased 30% from 2019 to 2020 and continue to rise. COVID laid bare three problems with the formal mental health system that we are stuck with: shortage of mental health professionals, long waiting lists to begin treatment, and the time it takes for therapy to be effective. With a shortage of mental health professionals in Cook County alone projected to be close to 30,000 in the next 5 years, something needs to be done to alleviate the mental health crisis that continues to unfold. This is where psilocybin service centers can move the dial. Psychedelic-assisted therapy can produce results quicker than conventional mental health treatment. Unlike conventional talk therapy, the work necessary to remit symptoms and increase functioning is done by the participant while in an altered state of healing. Psychedelic treatment centers will make a significant dent in a dangerously overworked system and allow more people to receive life-saving treatment than is possible currently. The last part of my testimony is one of personal tragedy. My 38-year-old daughter, someone with a dual diagnosis of mental illness and substance abuse, died by suicide on March 7th of 2019. I found her dead on a Thursday night, that terrible day in March. As a clinician and as a CEO, I spent the last years of her life helping her access the mental health system. This included both mental health and substance abuse. Finding a successful treatment modality was my priority as her father. Quite simply put, the system failed her. When she needed inpatient treatment, she did not meet the qualifications. When she was ready for treatment, she endured 2 days of intakes with no resolution. She gave up on a system that is too complicated and based on a medical model that is profit-driven. She gave up on living with no hope on the immediate horizon. Psilocybin may have helped her by facilitating internal insight into her condition. It could have saved her life, but it was not legally available, and I'm a firm believer that this modality will save lives. I thank you for the opportunity to speak on behalf of the plant and my daughter.
Thank you so much, Bruce. You are a fixture in access to behavioral health care in Illinois, and sharing your lived experience and the loss that you've experienced makes you vulnerable, and it's moving, and everyone who just heard that felt it. So thank you. Next, we are going to move to Jean Lacy virtual, and then we will hear from Senator Ventura and Rep. Ford about House Bill 1.
Thank you, Madam Chair, and thank you, everyone in attendance, for being here today to take the time to learn about this important issue. My name is Jean Lacy, and I am the founding executive director of the Illinois Psychedelic Society. But first and foremost, I'm a mom. I am from rural central Illinois. I live near Peoria. Professionally, I have worked for nearly a decade helping clinical organizations implement the state-regulated medical cannabis program. And I'm here today representing the Illinois Psychedelic Society, an organization comprised of doctors, psychiatrists, other mental health professionals, and harm reduction advocates. And we formed to stand in the gap, promoting informed understanding of psychedelics and broader access to this life-saving therapy in Illinois. I'm also here to share my own story. While pregnant with my youngest child, I spent 5 months hospitalized with life-threatening blood clots. In spite of attempted interventions, I still ultimately ended up with a massive clot that nearly took both of our lives. The challenges that followed that near-death experience included a months-long stay in the NICU for my son and multiple surgeries and years of medical interventions for me. It was truly a living nightmare. My husband went from being a full-time tradesman to my full-time caregiver while I struggled to recover physically, mentally, emotionally, and spiritually. A constant fear of death loomed over me and drove me into a cycle of debilitating anxiety and suicidal ideation. In spite of everything that Western medicine threw at me, including cocktails of pharmaceutical drugs, my condition only worsened, and with each failed treatment, I became more hopeless. As you've heard in some of the stories shared here today, I'm not alone. My journey from trauma to hopelessness mirrored the findings of a 2023 report that included a staggering statistic that suicide accounts for 39% of direct maternal deaths between 6 weeks and 12 months postpartum. 37% of the women who died were known to have a previous or existing mental health condition. This disparity in care is even greater when you acknowledge that Black women are nearly 4 times more likely to die during and after pregnancy, and Asian women are twice as likely compared to their white counterparts. Suicide is a major issue that cannot be understated. According to the Illinois Suicide Prevention Alliance, on average, every 5 hours and 41 minutes, a person dies by suicide in Illinois. They used to say that there are at least 44 a day. 1 out of every 3 deaths by suicide in the U.S. is a veteran. That makes more than 16,000 veterans a year across the nation. So if we wait to implement a program until psilocybin is FDA approved, By 2028, at 44 a day, more than 60,000 veterans will have died by suicide, waiting for new treatment options. Doing the math, about 3,000 of those veteran deaths would be Illinois residents. Preliminary independent research suggests that over 80% of veterans experience improvement after participating in just one psychedelic program. Fortunately, due to my enormous privilege, my story doesn't end with suicide. It took years before a compassionate doctor was willing to call my condition what it really was, complex PTSD. That shift in perspective set me on a course to dive deep into the mounds of research done by Johns Hopkins, University of Chicago, USONA Institute, MAPS, and other organizations. In addition to being indicated for treatment-resistant depression, PTSD, anxiety and end of life, alcohol use disorder, and smoking cessation, there are over 60 ongoing or planned trials testing psilocybin for indications such as obsessive compulsive disorder, anorexia and body dysmorphia, bipolar depression, migraine and cluster headaches, traumatic brain injury, and more. To say there isn't enough evidence simply isn't factual. Additionally, as previously mentioned, psilocybin has been used safely and effectively by indigenous communities for thousands of years. We would be remiss to ignore that wisdom. Around 60% of current clinical drug trials are studying the therapeutic benefits of psychedelics. Gaining this knowledge, for the first time, I saw hope for myself before realizing that engaging in this kind of healing was highly illegal in my home state. I'd be putting myself and my children at risk if I sought this healing. So in a last-ditch effort, I took a risk by traveling out of state to engage in a therapeutic process consisting of preparation, a psychedelic experience, and integration therapy. And even after a single session, I was able to break the patterns in my brain that were keeping me stuck in my traumatized state, and I was able to re-engage parenting my children. With this new neuroplasticity I gained from a few additional sessions of psilocybin treatment, I made profound changes to my entire lifestyle, and I developed the tools to be the present mother I always hoped I could be. My children were always thriving, thankfully to a supportive support system, but now at 17, 15, and 11 years old, they have an active, engaged mother to guide them through life. And after also overcoming the withdrawal from my prescribed psychiatric medications, I no longer rely on pharmaceutical interventions for my mental health, and I have the mental and emotional resilience to cope with whatever life brings to me. Leading a statewide community, I have the privilege of speaking daily to people who have stories similar to my own. These are mothers, veterans, teachers, and people from all walks of life desperately seeking relief from their suffering and having to become their own experts in alternative treatments that have yet to be integrated into our Western model. I want to be very clear. People are seeking this treatment in Illinois regardless of the legal status of psilocybin. The rates of use are rising here and nationally and will continue to do so as our mental health crisis flourishes. Under our current law, they either have to travel out of state, out of the country, or turn to underground, unregulated settings with a lot of unknowns and leaving gaps in effective treatment. In these settings, we don't know how facilitators are trained. We don't know where their experience with holding space for people in these altered states comes from, and we don't know where the product comes from, or if it's safe or not contaminated or how it was grown. And we believe this simply should not be the case when data shows that psilocybin is possibly the least harmful drug in the world with the lowest potential for abuse. There are currently no pathways to report abuses or harms that happen in these underground settings. We know that there are risks associated with consumption when not done responsibly and with informed consent. State-regulated programs like Oregon, Colorado, and the one proposed by the CURE Act provide access and reduce risk by creating regulated manufacturing, state-approved training, licensed service centers, and licensed facilitators. These programs provide adequate screening, appropriate set and setting for therapeutic experience, and support after the experience. This structure is focused on regulation, not deregulation. The whole point of proposing the structure of the CURE Act is to try and lower barriers to access for these treatment and provide safeguards for both clients and facilitators, and remove the fear of criminalization for people who are simply trying to ease their own suffering. The CURE Act creates a framework to allow existing community use to come out of the shadows by creating greater transparency, accountability, and opportunities for education. Under the CURE Act, we've asked IDFPR and IDOA to regulate the 4 license types related to psilocybin services. But it's important to emphasize that under this measure, there will be no retail sales of psilocybin. The intention is not for that to happen now, nor in the future. Only licensed facilitators who have completed a state-approved training program will be allowed to provide treatment. And resources are provided for community education and harm reduction training for first responders. We seek to be a responsible leader in the space of psychedelics. Including us, 23 states are actively investigating or pursuing legislative options to provide access to psychedelic-assisted mental health treatments, and nearly all of this legislation moves with bipartisan support. In Illinois, we have done our research. We have communicated with the people in other states who are here on this call. We've talked to our regulatory agencies. The point of the CURE Act is to try and figure out the best way possible to integrate this kind of program here in Illinois to help the people that live here. We have the opportunity to lead this broader movement by joining in other states like Oregon and Colorado and creating these standards of care, these protocols for best practices that will allow us to get broader insurance coverage and find new creative ways of providing access. The CURE Act is supported by dozens of community organizations and hundreds of mental health.
I'm sorry, I got to jump in, but we are running really tight on time. Can you wrap it up in like 20 seconds so we can hear more in depth about the bill?
Yeah, I have about 3 sentences left. So the CURE Act is supported by dozens of community organizations and hundreds of mental health and harm reduction advocates across the state. It focuses on equity and access by creating as many points of access as possible for this treatment, both as a client and a provider, allowing Illinoisans to create diverse business models that allow for a variety of pricing levels similar to what we see in Oregon, and by requiring the newly formed Psilocybin Advisory Board to review how this program can interact with state insurance. I cannot emphasize enough that there are serious consequences to continuing to withhold these medicines from those who need them. Let's not deny others the chance for healing. I urge you to support the CURE Act. Thank you.
Thank you, Jean, and I'm going to turn it over here in person to Senator Ventura.
Thank you. I'm Senator Rachel Ventura, the 43rd District here in the state of Illinois. I am the sponsor of SB 3695, which is the Senate version of HB 1. While there are some differences, I will try to keep most of my points to HB 1. But just to let you know what's happening in the Senate, we have 20 co-sponsors. Just about every veteran in the Senate side is a co-sponsor or chief co-sponsor on this bill, and it does have bipartisan support. That being said, I want to thank the chair and the committee for allowing us to speak today, and I want to thank all of the panelists who were very vulnerable and very precise in their expertise in their testimony. I want to give a simple explanation to what maybe some of the doctors have said. I am not a doctor, but I have done a fair bit of research in this. So a picture is 1,000 words. So what I've brought here is a picture of what they had spoke about earlier. Essentially, this is normally your brain and the neuropathways that it can create. And while it's on psilocybin, it opens up so many more pathways. And so that's basically what this is showing. But the medicine is half of the job. And I think you heard the testimony today that the therapeutic setting and the integration is so important. So while you're under the medicine, you may experience different pathways which may look like hallucinations or other altered realities. The bottom line is those pathways do not cement themselves by doing this medicine. It cements itself by creating new behavioral pathways, new mental thoughts with integration and therapeutic settings. What the medicine does is allow for neuroplasticity. It allows for these new pathways to be created. That is so important when you're talking about people with PTSD or complex PTSD, or those who the traditional settings and therapeutic settings have not been able to help. Essentially, they're stuck. And what happens with this medicine is it allows the brain to get unstuck and begin healing anew with a different pathway that it has not been able to explore in the past. So I hope that that brings it down to the simplicity of it. But like Jean, while I have been sponsoring this legislation over the last 2 years, I have heard dozens of stories, heartbreaking stories like Bruce, but also very empowering stories of people who have overcome their mental health. I too have a family member who is navigating this, the mental health setting we have in Illinois, and is currently using ketamine and S-ketamine through his insurance company. I am hoping that he will have a different outcome than Bruce's daughter, but unfortunately, a lot of it is looking the same. So when I say that this is very near and dear to my heart, I am afraid to lose a family member through suicide because he has attempted several times already. Our medical setting for mental health does not cut it for everybody in our state. We need to provide opportunities for the people who need this medicine in a safe setting. As Jean pointed out, there are people who are doing this already. Luckily, my family member does not want to go into the black market to receive the care that he needs. We should not have those opportunities restricted from people that we love and people in this room who may need some of this treatment. So with that being said, I would like to talk about what this bill does, but please know that you have in your hands the ability for hope, healing, and treatment of those hundreds of people, thousands of people in our state who really need this medicine today, including the 44 veterans a day who commit suicide. The beginning part of this bill sets out an advisory board. This advisory board has a number of medical professionals on it who will then set the best practices going forward for IDFPR to understand the training and licensing. Some of these practices will be modeled off of what Oregon and Colorado has done already, as well as the hundreds of therapeutic clinical trials that are in works today across the United States. The bill then lays out 4 types of licenses. The first is a testing license to test the product. The second is a manufacturing license. This is the individuals who would be growing the product. The facilitators would be the ones who were helping administer the product, and then the facility is the location that it would be used at. Again, there'd be no retail sales, so the only areas that you would be able to utilize this product is in a facility with a facilitator. It is possible for that facility to also be a manufacturer or grower and utilize their own product, but they would not be able to test their own product, obviously. There is a difference between the Senate bill and the House bill. Currently, in the Senate bill, we have required a referral, not a prescription, since this, as already previously stated, is not FDA approved. The idea is that someone would be able to maybe talk with their therapist or their doctor beforehand and be referred to a healing center and then be able to go there. So that is one difference between HB1 that currently does not have that in the bill. Part of the process, though, is about the set and setting. All of the clinical trials have shown that when individuals feel it is safe, they have a more positive outcome. This is really very crucial to this medicine. So when it says set, we're talking about the mindset and your intentions going into using this medication, and then the setting is the environment you find yourself in. So we've already talked that this would be highly regulated. A lot of training would go into the facilitators in the facility, making sure that they are creating a safe setting for individuals. Once that they have been referred to a facility, then they would need to go through essentially a questionnaire. There are some things that we would want to screen out, and the facility themselves could deny care. Since this is not traditionally, this is not a medical setting, this is a facility healing center. So there are some differences there. There would be some first aid type emergency services on hand, but a lot of that will be dictated by the rulemaking as we want the advisory board of medical professionals to make those determinations, not necessarily lawmakers. So we have allowed for that to be built into the rulemaking. Then once the individual has been essentially approved by the facility, there would be prep work where they would be setting their intentions. They would come back in another meeting to have it administered. It could be anywhere from 6 to 8 hours, again, depending on dosing, the way the person's weight is, and a number of other factors. They would be supervised the entire time. They would not be able to drive home, much like some of our rulemaking on ketamine clinics are today. And then they would have to do 3 integrations. So this is another area of difference between HB1 and SB 3695. In the Senate version, we have 3 integrations. The first has to be done at the facility. The next 2 can be done at the facility or can be waived if their therapist or psychiatrist, psychologist would like to take on those other 2. With HB1, I believe there's only 1 integration currently, and it is done at the facility. The bill also lays out the descheduling, but it also does put in the enforcement. This would be civically enforced. If the product is sold, it would be a tax violation, and so arrest could take place criminally if someone is selling the product outside of the licensing. So essentially what we've done is we've made the process or the business of selling this medicine outside of the system illegal, not the medicine itself. And then the last part of the bill creates a tax fund and talks about how those dollars in the fund will go back into supporting the agencies who have to regulate this and implement it.
Excellent. Thank you so much, Senator Ventura. Representative Ford, you are here with us virtually, and I'd love to turn it over to you.
Thank you very much, Madam Chair and members of the committee. First, I want to thank you, Chair, for allowing us to have this hearing. It's a long time coming, and I believe the people of Illinois, however this hearing turns out, deserves to have a hearing on an issue such as this. Secondly, I want to thank Bruce, and I look forward to meeting you, Bruce, and my condolences to you and your family, and thank you for being so vulnerable and fighting for your daughter's legacy. Let me just make it clear, Senate bill and House bill, both of them, there's no confusion about where we're headed with the outcome of the law. There would be one bill, a companion, that would be equal in the Senate and the House. So there's no problems between the Senate and the House. There would be one bill and they would be identical. The only issue right now is that the time had expired for amending any bill in the House. So you could look at the Senate bill as I believe the advocates have agreed to the language in the Senate bill, and that would probably become the language moving forward. But I'm sure after this hearing, we will definitely learn a lot and probably make more changes to the actual language of a bill that may be passed in lame duck or in the 104th General Assembly. And top of mind, of course, for all of us is to make sure that we recognize that the scientific and medical issues are top of mind, top of all of our considerations when we're thinking about and discussing psychedelic therapy. And we will look to experts for advice on the front end and throughout the process of crafting the bill and passing the bill. I tell you, the chair and Jean Lacy pretty much talked about something that's very important to me, and that is I want to address the importance of the aspect that of equity. In particular, we must learn from our experience, you all know, with the adult use of cannabis and apply it appropriately here, recognizing that this is not an identical situation, but we must learn from the past of how we implemented the cannabis. I think most of us would agree at least so far, grand expectation for equity in the adult use of cannabis market have not materialized. In the cannabis industry, the rich seems to continue to get richer, and the people in the small communities continue to try to fight to get in the budding industry. So today, I want to focus on equity and what that means for any bill that passes Illinois and beyond, whether it's House Bill 1 or Senate bill or any bill that becomes the bill that we push. To me, in this case, equity is about access to medical services being provided, as well as access to the marketplace for a diverse group of small business people who must be given an opportunity to build a successful business before the space is overrun by major corporations. So what does access mean to me? First, who is going to get these therapeutic services and who will pay for it? Treatments of trauma seems to be a major suggested use for psychedelic therapy. But if a single cost of therapy is out of reach for out-of-pocket payment, then I can tell you most of my constituents will not be able to get this treatment. So how do we make this therapy accessible to the people who need it the most but can't afford it? And so that will be a priority for me as a sponsor. Likewise, despite the state's best intentions, the cannabis industry has not been equitable on the business end. The cannabis industry is mostly owned by, as I said, the major corporations, and it's clear that we have to do more and be thoughtful to ensure that regular folks from underserved communities and those hurt by the war on drugs have a chance to access this industry in a meaningful way as owners and executives, and not just hourly employees. So these are some of the things on my mind today, and I look forward to addressing these questions as we move forward to pass legislation. And I really enjoyed the fact that we had people from both sides give testimony. That's how we're going to get to the place where we need to be for a safe therapy type of treatment for the people of Illinois. So thank you all for your testimony, and happy holidays to everyone.
Thanks so much, Rep. Ford, for being here virtually, adding that perspective and clarifying how the Senate and the House bill are mostly on the same page and have intentions to be on the same page. Way over time, obviously, but do we have any questions? It's because of the time issue. My perspective on all of this is, who do we have? Is that, keep me posted, Jason. We do have time for one question, so raise your hand virtually if you have one. But we're going to hear more about this specific bill, no doubt, and there'll be times where we're going to discuss this bill in whatever House committee, speaking for the House, that it gets assigned to, so there'll be lots of time for Q&A on the bill in particular, on and off the record, as people want to participate in the process. And what we did today was really zoom out and hear from a variety of stakeholders on what psychedelic treatment means for behavioral health treatment and access, and I don't think that had been done before.
I wanted to answer the representative's question from earlier about who would prescribe this. This is not a medicine that is FDA approved, so they cannot be prescribed by a doctor. So I think that that's what he was hinting at. Instead, this would be facilitators who would go through rigorous training. I think, as they spoke earlier, this is a very safe product. So it'd be like saying, what a doctor prescribed beer, for example, or, wine. I mean, that's the safety of which, in fact, is more safe than alcoholic. So when we look at who will be administering this product, that would be the licensed facilitators in a facility. And we have identified the level of education or occupation you would need in order to begin that training with a look towards equity. But that is outlined in the bill, and it does include things like doctors and nurse practitioners, but it does not stop there, as we understand that people who are in harm reduction also have an interest in this, and there would be abilities for them to go through the training as well. I hope that's helpful.
Thank you, Senator. Looks like we have one question from Rep. Howder.
Well, that's just it. That's what I was trying to get at. I mean, so you're saying that a medication which is not approved is currently illegal, and we've been told by the Psychiatric Society that there's not enough evidence to prove its safety or its efficacy, is now going to be administered by could be administered by non-medical people. So this is very concerning to me. In my mind, I keep hearing how safe it is and how effective it is. So prove it.
So I think that there's a lot of different medicines in the world. Some are prescribed through doctors and some are not. Caffeine is a medicine. We all self-prescribe caffeine on a regular basis. There are countries all over the world who utilize this outside of a medical setting. The country of Australia has included this as mental health care and prescribes it. There are 2 states in the United States today who are prescribing this, with non-medical providers who are prescribing this, all under licensed and regulated systems. That is what we are aiming to do here. I think that part of this is a stigma, and it is changing. I think Representative Terracotta Howard said it best, that it's going to take some time to educate and shift over what's happening and what is available out there when it comes to the statistics and the clinical studies and the training. And yes, there are some products who are trying to go through FDA approval right now, but what it's all pointing towards is there are mobilities in front of us that we can take if we choose to take it. We have abilities to help people if we have the political will to do so, and we can do it in a safe setting because of the type of medicine this is. But it does take us shifting our perspective and what we think of as a drug. It's unfortunate that this particular medicine got swept up as Schedule I back in the 70s. It really should never have been. And I think a lot of doctors would state that as well, but it was. And so now we have the burden of unpacking that for this particular medicine and showing how different it is from heroin and from opioids, which are readily prescribed today in America. And the reality is we have a fix to that that's sitting right at our fingertips. We just have to reach out and be willing to do so. I, of course, don't want anyone to be harmed by this medicine, and so we want this to be safe. But the reality is people are using this today, and they're doing so at their own detriment because they don't have people who are helping them find safe settings and safe mindsets to explore this medication and find the true healing that they need. But Illinois is in the right position to do so. So I hope we'll continue this conversation.
Well, thank you. Again, this is like a very serious conditions that we're treating, medical conditions. We have prescription medications for them. We're talking about life and death. We're talking about, serious medical treatment of suicidality or severe depression and PTSD. We would want the most, stringent safety requirements, the best research, and the most experienced, highly trained providers prescribing it. And in my mind, I'm just looking at this, and this is not what I'm being told. It's very concerning to me. I know we'll have more time to debate this, but I just think that if we're talking about how safe and effective it is, I'm all for it. So just prove it. That's all I ask. There's a process for proving it. And that's what I ask that we go through. Thank you.
I'd like
Thanks, Rep. Powder. We probably have time, well, we don't really, but if you want to take 10 seconds, go for it.
So I just want to riff off of what Senator Ventura said. Bear in mind that the DEA scheduling was a result of Richard Nixon's war on drugs, which targeted the people that were against Vietnam and minorities. And it's come out recently, direct quotes from one of his people, that this had nothing to do with safety. The scheduling was a political scheduling. So we are left with the remnants of a failed war that has cost more lives than it's helped.
Thank you for that, Bruce. You've got some fans in the audience. And we have Will Guzzardi, and then I'm going to see if Chair Yednock has any closing remarks as we finish.
I just wanted to add to this conversation very briefly. First of all, thank you for this wonderful hearing. It's been very informative. And I think to Rep. Powder's points, I think he's absolutely right that we need to make sure that there's like a solid evidence base before we proceed down this road. I think we've heard a little bit of it today, just like the challenges of studying scheduled drugs, right? And the limitations that are placed on research for these kinds of substances because of the scheduling. And also, I think just the sort of the sort of functional deblinding point earlier was really interesting, that, you know, in order to sort of meet the gold standard of these kinds of trials, you have to have patients who are unsure whether they're on the substance or they're using a placebo. And it's really hard for people to be unsure whether they're on psychedelic drugs or on a placebo, because it's very clear the difference in the patient experience. So yeah, I think there are just some, you know, I think further conversation about the structural challenges around medical research, clinical research for these kinds of substances, and what kind of research we can perform with these substances and what the results of that research actually show us. I think that'd be valuable for future discussions.
Thank you, Rep. Chair Yednock, do you want to say anything as we close out?
I'll just say thanks for having the Veterans Committee involved in this. Your first panel was very veteran heavy. And so we know there's obviously an issue there, and I'm sure that Representative Swanson will probably have more to say about this in the near future, but very interesting. I think I've got a lot of things to think about over the next General Assembly, so just thanks for having this, Representative LaPointe.
Thanks, Chair Yednock, and that was great turnout from the Veterans Affairs Committee. Appreciate everyone who stuck it out to the end, and those of us who are here for any amount of the hearing. With that said, the House Mental Health and Addiction Committee will recess till the call of the chair.